Thank you so much. Good morning. Thanks to Frank for having me here today. It's really an honor to be able to share our early work with you guys. So I'm going to talk today, as Frank mentioned, about how we can use the immune system to remove senescent cells. Put more simply, we believe there's a way that the immune system that nature intended for senescent cells to be removed. We've done the work to figure out what that process is. And as I'll show in the data today, when we can harness this properly, the results are actually quite striking. As an additional thought, as we talk about traditional drug development versus aging therapeutics and immunotherapies, just one idea I want to plant in your heads. Traditional drug development tends to have, a multiple pill burden regimen every day. 3-4 pills a day just to kind of feel normal to abate symptoms. Our view is when you actually follow the immune system, that you can be much more effective, much safer, but also drastically reduce the pill burden that traditional drug development will give you. So I'm going to show some of that data as well. Okay. All right. So just four parts of my talk today. First, I'll talk just a quick refresher on senescent cells, their implication in age-related diseases. Second, we'll talk about how we can harness the immune system to ablate senescent cells. 3, we'll talk about the impact and the data. So really the question is, I think 1 and 2 is interesting, I think mechanisms and targets are always fun to talk about, but number 3 is really where the rubber meets the road. So does it actually matter? Does the data represent some kind of paradigm shift in the field? And then lastly, I'll talk about the path forward. Okay. So first, what are senescent cells? How do we think about them? So these are cells that have been irreversibly damaged. They essentially, they'll pull the emergency brake. They kind of this altruistic kind of function initially. They go, okay, look, I've been irreversibly damaged. I'm going to exit cell cycle. I'm going to get out of the way. I'm going to go off to the side and not replicate anymore. But over time, what happens as we age and with disease, these things tend to accumulate. So the ability to get rid of these cells is compromised. So zooming in on this a little bit more, so this is a senescent cell we have pictured here. Senescent cells over time will end up exhibiting about 60 plus different SASP proteins. Just of note, of these 60 plus cytokines, TNF-alpha, TGF-beta are just 2 out of 60, but kingdoms of biotech have been built on just inhibiting those single cytokines. But that's only a small fraction of cytokines and inflammatory processes being exhibited by senescent cells. These are very nasty pathological cells. But the issue is not actually that they happen. The issue is that we can't get rid of them. And that issue lies in the immune clearance failing. So it's not that they exist, it's that our immune system does not react to them properly over time with disease and aging. And so when you have that, you have these primary senescent cells in the middle, and over time what will happen is through cell-to-cell contact, these cells, even healthy cells in the microenvironment, will also be forced to become senescent just by being in the same microenvironment as the primary senescent cell. So over time, what you get is chronic inflammation, you get fibrosis, and you also get stem cell exhaustion. So regenerative capacity you would normally get from stem cells is now compromised by the presence of these senescent cells. And that's really where the issues lie. Okay. I don't have to tell anyone in the room this, but just so you guys can get a mind map here, senescent cells are driving diseases with huge unmet need. These are just indications I could fit on one slide where senescent cells are thought to be causal in human disease. These are also indications, as noted in the references below, where people have ablated senescent cells in the literature and different research studies and shown that if you can do this successfully, you can treat diseases. And 3, as noted in the orange, these are massive markets. So these are things that are poorly managed right now, but have huge patient populations, generally pretty good payer tolerance as well. So these are just kind of our first set of roadmap as to where this kind of science can go if successful. Okay. So what are we doing at a high level? When you're young, you're healthy, your immune system is active, it keeps your senescent cells in balance, everything is fine. Over time with disease and aging, the immune cells, they don't go away, but what happens is they become anergic. So they get exhausted, they get tired. And so what happens is that it basically allows for senescent cells to start to accumulate. And so what we propose is with a small molecule immunotherapy, what we can do is rebalance this. We can activate the natural immune process that was intended to clear these cells. We can get rid of senescent cells. And what that does, as the data will show, is it effectively treats disease quite quickly. Okay, so how do we do this before I get to the data? The first thing we did is we wanted to be very robust in our platform. So the company vision was not to solve a single senescent cell-driven disease, but to solve multiple. And so the first thing we did is we actually isolated senescent cells from pulmonary tissue, from adipose tissue, and from diabetic pancreatic tissue. So 3 very, very different diseases. So we took the senescent cells out, we isolated them, we ran single-cell RNA sequencing. And just to it's a short talk, so just to summarize about 9 months of hard work in about 10 seconds, it's actually all published as well, so if you want to read about it, you can. We learned that natural killer T cells are actually specifically responsible for clearing senescent cells in a number of these different disease indications. So this publication came out last year, so like I said, this is the reference. If you want to read it, it's very interesting. Okay. And so now became, okay, now we think that NKT cells have some kind of role here, so the hypothesis is if we activate NKT cells, those will clear senescent cells. And two, and more interesting, the reason you have a company, if we do this, can you get a paradigm shift in disease treatment? So it's not about aging, it's not about removing senescent cells at the end of the day, it's about can you change the way certain diseases are managed and treated going forward. Okay, so this is the first POC data we've published. This is a very standard high-fat diet mouse model. This is a mouse that's been put on the high-fat diet for 16 weeks. So for 4 months, we don't treat the animal with any kind of medicine. We just let disease set in through these high-fat, high-fructose diets. During that 4 months, these mice become morbidly obese. They get systemic metabolic disease. They also get senescent cells building up all the way in the adipose tissue. With metabolic disease, as you guys know, you get glucose intolerance, insulin sensitivity is reduced. And so we want to see, can we bring this back now to normal? So now we've made the mice very diseased in 4 months. Can we make them normal once again? The timeline here, I'm going to take you through the data one by one. So at week 22, so 4 months after disease induction, we give one single dose of the NKT agonist. The standard is just a normal black sex mouse, normal weight, normal everything, no special diet. High-fat diet vehicle are the animals that are high-fat diet animals but have not been treated with the drug. Then high-fat diet proof of concept, POC, are the ones we've treated. So the first thing we see, 4 days after we give the drug, we see a nice target activation of the immune cell of interest. Now we know we've hit the target in the animal. Now we see a beautiful reduction in senescent cells. So now you see the senescent cells are reduced down to the normal levels of the age-matched black sex healthy mouse, whereas the HFD vehicle, the one that's not been treated, still has a high degree of senescence in the adipose tissue. And now the rubber meets the road. So what actually happens? So the first thing that happens is the mice become less insulin resistant. And this happens 10 days after the single treatment. So you treat on day 0. By day 10, you start looking at endpoints. So now the mice become less insulin resistant. And what happens with that single dose again is right there in the middle, that orange line represents a glucose challenge to the mouse. So when you give the mice a bolus of glucose, you want to see, can these treated mice handle that glucose more effectively as though they don't actually have metabolic disease. And so we see a really nice normalization of the glucose tolerance curve, almost back to normal of the healthy age-matched control mouse. And the mice on this treatment don't lose a lot of weight. It's not driven by weight loss necessarily. It's just driven by removing senescent cells. So the paradigm shift here is we've only given this once. So you think about current diabetes treatments today, you're taking multiple pills a day, sometimes bad side effects, some are effective, but you got to take quite a few of them to actually get some kind of improvement in symptoms. This is given once, and what's nice about senescence removal is that this effect is durable. So we see that this effect lasts for several months actually. So you give one dose, day 0, you would then get a dose again by Q2, Q3, Q4, a very intermittent, cleaner dosing regimen than current standard of care. Okay. So the second proof of concept study we've done that we've published is around pulmonary fibrosis. So, and this is a very different model. If you're not familiar with the pulmonary fibrosis model, it's basically an injury model to the mice. You give them a bleomycin treatment through the mouth. They get senescence in the lung tissue. They also get fibrosis in the lungs. If you go to a dose high enough of bleomycin, you actually will kill most of the mice. And so we also did a survival study as part of this. So very similar approach here, same drug given systemically. Nothing all that different in this idea, except that the model we're working with is very, very different. But the question is, can we have the same impact with this model? So again, we have a nice activation of the NKT cells. These senescent cells are drastically reduced in the lung tissue with a single dose. The fibrosis is halted in this process. So this is, pulmonary fibrosis. The goal is to actually halt fibrosis. And then lastly, even in a separate study with our academic partner, they did a lethal dose on the animals. All the animals who did not receive the treatment died, whereas the ones who actually received a single dose had pretty good survival several weeks after that installation of bleomycin. So again, same idea here. A single dose has a durable effect. This will last for several months. Current IPF treatments right now are, 1, massively expensive, 2, minimally effective, and you're taking 3 to 6 pills a day with nasty side effects. IPF, though, is driven by, if you look at any of the human tissue and IPF data, Senescence is on the leading edge of IPF progression, so we think this is a really good place to use this technology. Okay. So what are the advantages overall of this approach? First, like I said, durable endpoints. So we're not talking about dosing every day, we're talking about dosing intermittently. Two, it's systemic. So, we think about age-related diseases now. Typically when you have age-related diseases, you don't have age-related disease, you have age-related diseases. And this is a systemic way to get rid of senescent cells all the way throughout the body, from the neck down. Three, this is, like I said in the beginning, this is the innate mechanism. This is the way we believe nature intended for this process to happen. We figured out what that is and can now harness it for good. There's a precedent for safety with NKT agonists, where people have shown before that even in cancer studies, activating NKT cells is an effective, not effective in cancer, but a safe mechanism to use for immunotherapies. It's robust, like I said before. It didn't really matter how we induce diseases. We could do it through diet, we could do it through injury, do it chronic, we can do it acute, but the effect with a single dose was still the same. And then lastly, it's got a very attractive cost of goods. So if you recall from the beginning, this is a small molecule immunotherapy given intermittently at low doses. We gave 2 microgram doses to these mice. That's about a 3.5 to 7 milligram dose in humans one day given quarterly. Is the vision. So you just do the cost of goods, small molecules. This is for everybody, not just for the haves. Okay. Now, dovetailing this against traditional drug development, the mechanism of action here is multiple versus single. Traditional drug development tends to focus on more of a single mechanism of action. When you talk about senescent cells, like I said, they're very inflammatory. They drive fibrosis. They cause stem cell exhaustion. So by getting rid of one of these nasty types of cells, you're actually doing multiple things at once. Two, we're focused on indications where senescent cells are believed to be the causal part of the human pathology, so really driving disease. Most drug development approaches today tend to be lots of pills, they tend to be symptom modifying, tend to make your numbers look better, but don't actually treat underlying disease. And that's why you have to take so many pills so frequently. Like I said before, disease modifying versus disease management requires no further explanation for me. That's obviously where you want to be going forward. And lastly, when you think about traditional drug development, it's simply about blocking an enzyme, blocking a kinase, blocking some kind of receptor. We look at the best way to treat disease is just rebalancing the way things should be. So just bringing the immune cells back up to how they were intended to act in the first place and how they did when we were younger and disease-free. Okay. So as we go forward, we're currently in early development with our lead compounds. The next milestone of that will be the IND and first human safety, and obviously then human POC studies after that. In the background, we're working on additional programs. We're now functionalizing this not just towards indications that are neck down, but also now starting to look at the brain and how senescent cells build up in CNS disorders and how the immune system can take care of those. We're also doing pipeline expansion where we look at additional POCs behind the curtain that I didn't mention today, so HFD and so type 2 diabetes, IPF we talked about today, but in the background we're looking at more senescence-driven indications that NKT cells can be impactful for. So in summary, we're therapeutically harnessing natural killer T cells to ablate senescent cells and treat disease. The in vivo data supports a significant paradigm shift versus traditional drug development. Future milestones include platform expansion and first-in-human studies. A big thanks to a couple of our pharma sponsors in our lab, Eastside and AbbVie, who have helped us offset some of our lab costs. Some of the recent news in the last year that came out when our publication. And of course, thank you to everybody. We are not currently raising right now, but if you want to hear about a future round, please let me know. We've raised about $16 million to date. The next round will be focused on covering the phase 1 studies. So happy to have those conversations now and get started early and think about how we could work together in the future. Thank you so much.